was part of the steering committee of the AGENT trial, and we presented a whole bunch of data this meeting of the subgroup analysis. And it's remarkable how consistent the data is, whether you look at small vessel, large vessel, minority population, different genders, as well as multi-vessel or rather multi-layered stents as opposed to a single layer stent. I thought I'll talk about vessel prep, because I think that what was successful in AGENT was that we kind of instilled in everybody that this is just a drug delivery balloon, and it's not a balloon to dilate the vessel, right? And I think the take-home message is that is dealing with in-stent restenosis is nothing to do with the final balloon you put in to deliver the drug. It's everything you do before that, and it's a lot of hard work, right? The PCI that you do for in-stent restenosis today is probably the hardest thing you'll do in your cases. It's not a type A lesion that you slam in a balloon and be done with it, right? So it's a lot of thought process that goes into it. Even though we didn't mandate intravascular imaging in the AGENT trial, we luckily got 78% of our investigators do imaging for these cases, which we were very lucky. So I think that made a difference, and I think that shows in the clinical trial results. So let's just talk about this. So we talk a little bit about this. So I'm going to jump into a case, and I want it to be kind of a dialogue or interaction or whatever you guys, just stop me and we'll talk about it. So this is a 72-year-old lady that was sent to me from Bakersfield, and I practice in Los Angeles, and we get a lot of these cases from the valleys that have a huge burden of disease. This lady was 30, her BMI was 35, very nice lady, had been through, she had obesity and sleep apnea and hypertension and diabetes, and eventually, succumbed to the ravages of coronary disease, where she became ischemic and had ischemic cardiomyopathy on top of her diastolic dysfunction. She still worked. She worked in a grocery store. She now worked in a wheelchair, or rather, the electric chair. And she could only do stuff with her upper extremities, because every time she stood up or did anything, she got more angina. So anyway, this is her EKG. Not very threatening, but you can see the Poirot progression across the precordium, right? And this was the angiogram that was sent to me. You see the right coronary artery, right? It has she has stents in all three vessels, and see if it works. Maybe not. All right. So here you see the osteal lesion in the right coronary artery, and then she has a occluded left anterior descending artery, and she has this horrible restenosis in the ostium of the circumflex. So this is the angiogram that she came with that was done in middle of 2023. So when I saw her, she was having a lot of angina. I didn't really know what her disease was. So I put her on the table, and I realized that I wasn't equipped to fix her on that day. So all I did was an OCT of her circumflex, and that shows you all the different things that happen inside a in-stent restenosis. So you start with this eruptive nodule of calcium that's at the near ostium of that stent. You see a in-stent restenosis with neointimal hyperplasia in the middle of the stent. And towards the distal edge of the stent, there is what we call a under-expansion of the stent. So 3 different pathologies of in-stent restenosis in one stent. Anyway, so she was sent to me originally to fix her occluded LAD. So that's what we did first. We fixed her LAD. We did a star angioplasty of her LAD. There's not much we could do because it was a diffusely small vessel. And that we did in January of 2024. At that time, she had some dampening of her right coronary artery, so we balloon angioplasty the ostium of that stent, and we left that alone. She comes back to me. So let's just talk about in-stent restenosis. And this is a schematic that we came up with in understanding how you manage in-stent restenosis, right? So the first part is if you have neointimal hyperplasia, the neointimal hyperplasia is probably focal, or diffuse, or proliferative. This goes back to the original Meron definition of in-stent restenosis in the acute phase. And depending on what it is that you see, you will decide therapy for it. And that could be just plain balloon angioplasty, scoring or Wolverine angioplasty, or laser, or whatever you like to do for that. Where the stent looks appropriately deployed, but that there is neo-intimal hyperplasia. The second part is later on that we are seeing today is patients come back if a stent was placed 6, 7, 8, 10 years ago, where they come in now with new atherosclerotic plaque. And that new atherosclerotic plaque can be either just a lipid-rich plaque, or it could be more heterogeneous, where there's calcification, or it could be nodular calcium inside the stent. And then the third phenomena was the stent itself and the surrounding tissue around the stent. So we euphemistically call it what's going on outside of the stent. Is the stent what we call round and fully expanded? Is it eccentrically compressed, right? Is there like an external compression that's occurring? Or it's a missized stent that was never fully expanded or poorly sized, right? So all these things need to be put together on your imaging, right? So that's kind of what we came up with. So when you plan your therapies for in-stent restenosis, think of all these things when you think about it, right? What is happening? Why is it happening? And what is the solution for each aspect of that? So here it is, right? She comes back to fix the in-stent restenosis, and you see the nodular eruptive calcium that I saw on the OCT. That same image is represented on the IVUS on the top frame, right? Where the lumen area is about 6.5. And that is after I dilated it with a 3.5 NC24 balloon to 30 atmospheres, right? So this is a highly restrictive lesion. And then the distal edge of that lesion is this non-expansion of the stent, right? So that's what happened. So I did that, and the nodular eruptive calcium, there's one, it's very hard. It's much easier to treat it before you've stented it. It's much harder to treat it once you've stented it. So I pulled a shockwave balloon because that was the only thing I could do to reach that nodular calcium behind the stent. So I put a 4.0 shockwave balloon and did as much as I could, gave all my pulses in that one location because that was my issue. And then I went up to a 3.5 NC24 balloon in that location to 30 atmospheres. So that left me with this neo-intimal hyperplasia in the middle of the segment, right? So here it is now. You see this angiogram. It's still not perfect. I've gone from somewhere in the 6.5 range to 7.4. The Gestalt numbers for what area you should reach ideally, if it's a 3.0 vessel, the minimum lumen area should be 6. If it's a 3.5, it should be at least an 8. If it's a 4.0, it should be at least a 10. This is a 4.0, probably a 4.5 vessel. But even if you call it a 4.0 vessel, I want to reach a minimum lumen area close to 10, right? I may not reach there, but that's my goal. So in your mind, when you plan your procedure, you think of the vessel size and think about what you end up with and what you want to end up with, because that's going to be the maximum benefit for your management. So now I pull a laser because there's this non-expanded segment of stent in the distal vessel. So I take a 0.9 laser, right, and we fire it at 80/80. We call it, laser on contrast that allows the tissue, the fibrotic tissue around the stent to become softer, and then I post-dilate it with a 4.010 Wolverine. Now, why do I pull a Wolverine in that situation? The Wolverine, one, you can go to high atmospheres. Two, it will not watermelon seed through the neo-intimal hyperplasia. It'll grip it and rip it. That's how we look at it. So I thought this vessel was 4.5. I chose a little bit undersized Wolverine, a 4.0 Wolverine, and I went to 20 atmospheres on the 4.0 Wolverine. Remember, the usual use of Wolverine has a rated burst of 8 to 12, right? But we go very high pressures, right? And as long as you undersize the Wolverine, you can go to very high pressures and not risk a rupture or tear in the artery. And this is what we got as our final result, right? So looks much better. Remember, my aim was 10. I got to 8.99. Not exactly where I wanted to go, but close enough. We put a DCB in this situation. Remember, she had 2 layers of stent already to begin with. She has a great result. She's now almost a year out. This was done in the early part of this year. She's a year out. She has not had restenosis. Thank goodness. So much for that, right? So any questions on that? Any concerns? Any thoughts? Anything you do differently? No? Okay, we'll move on to the next case. Okay, so this is a guy that I did who I've been taking care of since 2009. He originally came in with the left circumflex STEMI and had a occluded large dominant circumflex, which I stented. At that time, he had an occluded LAD. This was 2009. We didn't have a modern techniques of PCI for CTOs. He had modest angina, managed him with meds, and he was doing okay. In 2013, we first decided to try his LAD CTO. So here is that LAD CTO. So you can see the non-dominant right coronary has this huge RV marginal or conus branch that fills the LAD. You can see the large dominant circumflex that gives that branch inferiorly. This was the 2009 angio, and this is now the first attempt in 2013. So what we decided to do, because the proximal cap was ambiguous, we put an IVUS in there. We said, okay, we'll find that proximal cap, we'll stick it, and we'll put a wire in there. And you can see that IVUS adjacent where you can see the 2 wires dancing where we're trying to find the lumen. Well, we tried for a while, didn't really have success. We didn't think we had good retrograde collaterals at that time, so we stopped. I bring him back, now he's getting more, as he gets older, he gets more diastolic dysfunction, his angina gets worse too. So now I bring him back for definitive therapy, and this time I'm willing to go retrograde on him. And I go retrograde through a epicardial collateral from his circumflex, actually septal collateral from his PDA, of the left PDA into his LAD. Anyway, we're successful, reverse cart. And if you guys have never seen what a subintimal crossing looks like, in this IVUS, you'll see the bouncing. You see the compressed true lumen behind it and your subintimal in that space, right? So the question is will a stent do well in a subintimal space? And in general, our assessment is that stent failure is a little bit more common in a subintimal space than in a native vessel, but it still does relatively well. So this is now 2017, right? He does well for a while, and then comes back in 2022, now with an occlusion of his LAD, has a large PET abnormality on his PET scan in an anterolateral wall, and here's the angiogram. You can see that LAD is occluded, exactly where we thought, where his stent had been placed in the occluded LAD on the CTO. So now we enroll him in agent. We're at this point enrolling in agent. We cross fairly easily with a workhorse wire. He has tremendous amount of neointimal hyperplasia. We decide to laser it with a 1.4 laser at 60/40, 2 passes. We do a Wolverine angioplasty of that entire segment, and then we enroll him in agent. He gets randomized to no DCB, so he gets randomized to a regular balloon. So now he gets a good result. He gets a really good result with his angioplasty, but now comes back in 2024. This was last week, right? And it's September 2024, maybe 3 weeks ago. He comes back, and here's his IVUS. You can see there is neointimal hyperplasia and that entire segment of his LAD that we had enrolled him in agent and just finished up with the balloon. So now we just put a Wolverine balloon down, re-expand the vessel. The MLA improves from the 3.5 to 7.5 to 8.5 entire segment. We put a 3.5/30 drug-coated balloon in him, and he does well. So I think that the concept of this is that you want to do the best job you can, finish off your PCI, and then, just like we randomize an agent, use the agent balloon to finish off. And once you put the agent balloon in, you're essentially done. We don't encourage at this point to do any additional ballooning or imaging or anything. I don't think that the drug will rub off, and because it gets incorporated pretty quickly, it's a lipophilic drug, the crystalline paclitaxel is. So it gets incorporated. But nonetheless, we kind of have avoided recrossing the vessel after we put the drug-coated balloon. This is a guy I did right before I came here. This is another patient that was referred to me, 73-year-old who's had previous bypass. He's an executive, lives in Bakersfield again, has a Lima to LAD and a vein graft that's a jump graft from D1 to M1, and it's reported to me that his right coronary artery is not dominant. He has a lot of other disease that he's managed medically. His last PCI was in 2020, where he had this so-called double barrel stent of his left main and his ramus. I don't quite know how they did it or what they did, but that was the note, right? I don't have that original angio. Now he comes in with this large anterolateral defect and recurrent angina. So here's his angiogram that I do when I see him. His right coronary artery is clearly not non-dominant. He has a focal severe lesion there. He has a jump graft from his marginal to diagonal. He has a touchdown lesion in the jump graft, and his Lima to LAD is patent. I'd have much rather fix those two, but he was sent to me for DCB of this left main to ramus bifurcation. So here's that left main ramus bifurcation. You can see that there's this osteal cramping of the ramus, and I couldn't even pass an IVUS, so I put a 2.0 balloon down into that. I wired the circumflex, wired the ramus, and then here's the IVUS. You can see at the top, the lumen after a 2.0 balloon is 2.6 at that origin of the ramus stent. I dilated with a 3.0 NC24 to 30 atmospheres just to make space, and then to decide what I want to do. Okay, so here is the circumflex now, right? So you can see the proximal circumflex, or the left main part of the circumflex stent. You can see where it's tight again in the middle. And angiographically, it doesn't look that tight. But on the IVUS, the lumen area there is 3 millimeters squared. This is where the ramus and the circumflex coincide in that bifurcation, where they think they did a double barrel stent. But I don't think they did a double barrel. I think they try to do a T or a reverse T or something, and the stent is protruding in there. And you can see the distal vessel size, which is 8 millimeters squared. So anyway, so now I do a 4.024 NC24 to 30 atmospheres just to make room. And here is I figured the best way to expand that non-expanded stent in the ramus was to do a very high atmosphere Wolverine balloon. So I take a 3.0 Wolverine, right? Remember, I think this is a 3.5 vessel. I undersize it, and I dilate it up to 26 atmospheres, right? And then I remeasure the IVUS. The lumen area goes from 3.55 to 6.06. I think I've achieved enough room there so that I can deliver a drug-coated balloon. Simultaneously, what I did with the left circumflex, which I did not want to put a balloon or drug-coated balloon, because I didn't want to spend money on 2 drug-coated balloons on this case. So I did just a balloon angioplasty of that with a 4.0 balloon, and I got a pretty good result on the left circumflex. My final lumen area there was almost a 9.5 or something. Anyway, I finish off with a KISS just to make sure the struts are out of the way, and then finish off with a 3.0 agent balloon into the ramus, and I left the large vessel alone. Remember, we presented the large vessel, small vessel data today, and the efficacy of the drug-coated balloon in diabetics with small vessel or non-diabetic with small vessel is actually numerically larger than in large vessels. So we were shocked and surprised, thankfully, that it works so well in small vessels just like it does in large vessels. Because we were concerned that maybe because of late lumen loss, that it would not work as well in small vessels. But thankfully, across the board, the drug-coated balloon has a pretty positive result.